Hi, I'm David Levine. I'm co-chair of Science Writers in New York. My other co-chair is behind the scenes, running the cameras and also taping this for YouTube. My guest is Apoorva Mandavilli. Hope I pronounced it right, maybe not. Okay, and this is the second time she's been with us. She's a reporter for the New York Times, focusing on science and global health. She currently covers the coronavirus pandemic, the monkeypox outbreak, vaccinations, the World Health Organization, and the CDC. She was part of the team that won the 2021 Pulitzer Prize for Public Service for coverage of the pandemic, and was also a member of the team that was a finalist for the 2021 Pulitzer Prize for national reporting. She's the 2019 winner of the Victor Cohn Prize for Excellence in Medical Science Reporting, and has won numerous other awards for her writing. Many of you might know her as the founding editor-in-chief of Spectrum, an award-winning news site on autism that grew an audience of millions. She led the team there for 13 years. She joined the Times in May 2020 after 2 years as a regular contributor. So anyways, thank you for agreeing to do this, especially 2 days before Thanksgiving. And so I just want to, read something. There was an article today by Associated Press, written by Mike Stobbe, which said, as Americans head into the holiday season, a rapidly intensifying flu season is straining hospitals already overburdened with patients sick from other respiratory infections. More than half the states have high or very high levels of flu, unusually high for this early in the season, the government reported last Friday. Those 27 states are mostly in the South and Southwest, but include a growing number in the Northeast, Midwest, and West. This is happening when children's hospitals are already dealing with a surge of illnesses from RSVP, which is respiratory syncytial virus, a common cause of cold-like symptoms that can be serious for the infants and the elderly. And COVID-19 is still contributing to more than 3,000 hospital admissions each day, according to the CDC. So that's why we talked about a triple pandemic. In Atlanta, Dr. Mark Griffiths described the mixes of viral Yambala. He said that Children's Hospital is an area of at least 30% more patients than usual for this time of year, with many patients forced to wait in emergency rooms for beds to open up. So, and one last thing is the winter flu season usually does not get going until December and January. Hospitalization rates from flu haven't been this high this early since the 2019 swine flu pandemic. The highest rates are among those 65 and older and children under 5. And it's important for people to get vaccinated, and flu vaccinations are down from other years. So happy Thanksgiving, everybody. So what is this? What does all this data say to you?
Well, this data says we're in for a pretty rough winter. First of all, thank you for having me. It's nice to be back, even if it is under sort of grim circumstances as always. I think I'm the queen of doom these days. But I actually think, we could get lucky. It may not be as bad as we think it, we hope it won't be terrible, because we haven't actually seen all 3 viruses, the flu, the RSV, and COVID, coronavirus, all at the same time, really. They sort of outcompete each other. So if that happens, maybe it won't be so bad, but you're right that already we're seeing pretty high rates of hospitalization. We're seeing a lot of cases. I think we already have had 4-point-something million cases of flu, which is really high for November. And you said, that the hospitalizations have been the highest since 2019. They're actually the highest in a decade. So this is really unusual to see this much activity for flu this early, and also for RSV. And of course, the coronavirus, we don't know it as well. So we don't know exactly what its seasonal patterns will end up being, but there's certainly the specter of these new variants. So altogether, any one thing may not have been enough to really cause a big crisis, but I think all three together is not a great mix.
No, well, I know Australia had a very rough flu season, and then it migrates here. I guess one thing to do is to encourage people to get flu shots, which people for some reason aren't doing. People aren't getting the bivalent booster or any boosters. The basic vaccination rate hasn't moved at all. So besides reporting on it, what can we do? I mean, they said that the American Academy of Pediatrics and Children's Hospital Association this week urged the Biden administration to declare an emergency amount of national response to the alarming surge of pediatric respiratory illnesses. An emergency declaration would allow waivers of Medicaid, Medicare, or Children's Health Insurance Program requirements so that doctors and hospitals could share resources and access emergency funding, the group said in a letter. So,
I mean, this is a long-standing problem. This predates even the pandemic, that we haven't had a lot of pediatric hospital capacity in this country at all. There are very, very few pediatric beds in a lot of parts of the country because it's not profitable for hospitals. And so they, tend to favor the older, adults, because, adults get surgeries, they have chronic diseases, they're just more profitable for hospitals. So we were already looking at pretty low numbers of hospitals. And then during COVID, a lot more of the hospitals became just sort of for adults because adults were the ones getting really sick. So we really moved away from this idea of kids getting sick, and we're sort of less prepared, I think, mentally for kids to be sick this year. And also, you said the vaccination rates are pretty low. The flu vaccination rates have never really been very high. They're always around 50% of adults. And I think it's about that this year too. But we would hope it would be higher because, as you mentioned, Australia and New Zealand had a really horrific flu season. And that's generally our signal for what might happen here. So we are expecting to have a pretty bad season here, although we weren't expecting it necessarily to come this early. But because it did go into Australia and New Zealand, we did have a pretty good sense of what the strain might be, and it hasn't changed. And so the vaccine is actually a pretty good match this year. So I think there's every good reason to get the vaccine, but people, I think, are sick of getting vaccines. Is my guess. They hear get a flu vaccine, get a COVID vaccine. They're like, I don't want to get anything. I've been getting doses for the last 2.5 years. So there's just some level of fatigue. I mean, we've seen such a small percentage of people getting the booster too, but I'm not so sure that everybody even needs the booster at this point. I think I'm not sure how much good the booster does, because if it's a good booster, if it's really well matched to the variant, it'll do a lot. But this year, the variant that's coming through, the variants that are coming through are really immune evasive. So, this bivalent vaccine is going to do absolutely nothing to prevent infection and serious illness, severe illness, death, that most young people are not at risk of that. So really, we're talking about older adults, high-risk people, pregnant women, immunocompromised people, immunocompromised kids. That's who really needs the bivalent vaccine. So in a way, I'm really glad that today the Biden administration has come out with this big push, the 6-week push to get the vaccine to minority groups and to older adults. And I think that's really what was needed, a really targeted push rather than everybody go get it, because everybody was not getting it. So I think this makes more sense to meet the populations that are at high risk where they are. They're planning to go to, libraries and county fairs and sporting events, and they're going to have ads on TV to try and reach Black and Hispanic populations. Mm-hmm. And for older adults, they're going to really crack down on nursing homes and make them educate their residents about the vaccine and offer the vaccine. And nursing homes that have really low vaccination rates, they said, might face scrutiny and penalization of some kind. So I think they're trying carrots, sticks, they've got throwing a lot of money at this. They're trying every approach to make sure that at least the high risk groups get vaccinated.
So right now, vaccines are free. I can get through my insurance 4 test kits for COVID, which is nice. I had to take Paxlovid. That was free because it's emergency use authorization. At some point, though, these things are not going to be free, and that's something I worry about. When they're, when it's free, it's like, okay, it's free, I'll take it, But what's going to happen when it's, these things aren't free? And the other thing is that I think the home health tests are great. As I found out, they're not as accurate as I would have hoped they would have been. But there's also no home test for the flu, and the flu and COVID have very similar symptoms. Or they do pretty much similar symptoms at times. So that'd be a great thing to have someday too.
Well, if you think about it, I mean, I think it is good to have a test at home, but to be honest with you, if you have symptoms, you shouldn't be going out. And if you don't have symptoms, why do you really need to test? I think we've gotten really into this idea of testing at home, but we don't really test for other infectious diseases. And if you're sick enough with flu that you need medical care, and you think that you might, want treatment, you're going to go to the hospital and they'll test you there, and they'll know whether you have flu, in which case they'll give you a Tamiflu, or you have COVID, in which case they'll give you Paxlovid. But if you're not sick enough to need medical care, the only thing you're really going to do for any respiratory virus is make yourself more comfortable, take Tylenol, or take a steam shower, or use one of those, neti pot things, or whatever, symptom relief. So I'm not sure how much good the tests really do beyond telling you, yeah, you have something, you should probably stay home and rest.
Okay. Well, I guess that, they do recommend a test if you're going to go to a big gathering with people or a family gathering. Does that make sense?
I think it does, but we have so many things at this point that I think if you're even, a little bit symptomatic, you should just wear a mask, especially if you're around high risk people. As you said, the tests are not that great. So unless you're going to test multiple times leading up to this, whatever event it is, you're really better off just protecting yourself in other ways, or protecting the people around you who might be high risk in other ways. I think the test only gets you so far anyway. And I think taking a test and getting a negative result sometimes gives people a false sense of safety, when actually the test might not be all that accurate.
Okay. So if you have questions for those listening, and I'm always grateful for those listening, especially 2 days before Thanksgiving, please put them in the Q&A box and I will read them. I have one question. Has there been talk of another booster after the bivalent booster?
There is a lot of talk about boosters. There's not talk of any one particular one because we don't know what variants will come through, but there's a lot of conversation about which variants, which boosters would be most helpful. So it's really clear that the current strategy of constantly chasing after the variant, trying to match and trying to guess is not working very well, because the coronavirus is mutating at a much faster rate than flu, which is where that strategy comes from, of like looking at current cases, trying to guess what we might have and developing a vaccine that way. But the flu has been mutating much slower, so it's higher chance of success, even though even with flu, we don't always succeed. But with the coronavirus, it's like you're always chasing these variants. So there are two things that I think could help. One is sort of a universal coronavirus vaccine. So you would target some of the more conserved regions of the coronavirus so that it doesn't matter which variant it is. There's enough parts of the spike that the antibodies recognize that they will work anyway. But that's really hard to do. They're hard to make because the parts of the virus that are conserved and aren't as crucial for the virus to sort of dock in are also not as immunogenic. You won't get a stronger response with the vaccine. So it's a little more tricky to do that. And the other option is a nasal vaccine, which would prevent infections, because clearly, we're in a good place with severe illness and death. The mRNA vaccines do that very well, but what they don't do well is preventing infection because what you need for that is mucosal immunity. You need immunity in your nose and your throat and all the mucosal surfaces where the virus comes in first. So if you don't have that, you could be really protected against all the really bad outcomes, but you could keep getting infected. So a mucosal vaccine, which is basically a nasal spray or something like that, would be great. Except again, that's also really hard to make, and it's not clear if a nasal vaccine does work really well, how long the antibodies will last. It's not clear, whether they will actually raise a strong enough immune response. There's lots of questions basically, and the Biden administration has not, I would say, spent enough time really thinking through these alternatives. They kind of, really banked on the mRNA vaccine. So we're behind the curve. We're behind lots of other countries in thinking about these things. And we, now that there's actually no money to develop anything with COVID, for the government, I think we're probably looking at having companies make vaccines and things costing a lot of money. So we'll see what happens, but it's not looking great in terms of those other options at the moment. I think in a couple of years, we'll have more options.
So here's a basic question. What exactly is RSV, and why is it surging now?
RSV is respiratory syncytial virus. It's a pretty, old virus. It's been around for decades at least. And pediatricians are really familiar with it because every year in normal times before the pandemic, kids would get sick with it. A fair number of kids would get sick with it. And some older adults were also getting sick with it, but people didn't really realize that older adults can get sick with RSV, so they weren't testing, and so they didn't know. It's like that old thing: you don't test, you don't know, and you think there's no cases. But now, actually, it's looking like now that there's more testing that for older adults, the RSV infections might be as bad as flu. It could be on the same scale. And for kids, really little kids, like under 1, it can be pretty dangerous because all respiratory infections that are severe are dangerous for those kids because they have really small airways and can get easily congested and develop bronchitis or bronchiolitis. And so it's a severe disease for some subset of kids who end up in hospitals. And in the US, we haven't really had more deaths than 200 or 300 a year. So it's not a huge killer, but it does send a bunch of kids to the hospital. And in other parts of the world where it's not as easy to get breathing help, ventilators and things like that, more kids die. So, every year worldwide, there are about 100,000 deaths. So it's a fairly big issue, especially in other parts of the world, but it's just not as talked about as some of these other things, partly because, we didn't have a vaccine. There's really no treatments, and there won't be because it's a very fast infection. So really, why talk about something so explicitly when I guess there's nothing to do for it is part of the thinking. But now there are actually many vaccine candidates. So now there's sort of more interest in let's really figure out what's going on with RSV, because we now finally do have these vaccines. There was a very cool, you're all science writers, so you'll appreciate that there was this scientific sort of hurdle to developing the vaccines. And in 2013, the NIH sort of figured it out. And then all of a sudden the vaccine development opened up. Until then, it was dead. And in fact, one of the vaccine candidates made infections worse. So there was a lot of sort of missteps and twists and turns in the story. And as far as why it's worse this year, it's because, this is our first winter without precautions. Before pandemic, kids were getting sick, but not in huge numbers, because every year some number of kids under 1 would get really sick, right? Mm-hmm. But this year we have a bunch of kids who the last 2 winters were not exposed to RSV. Normally a kid will be exposed to RSV by the time they're 2 and build up some immunity. But this year we have all kinds of kids, 3, 4, 5-year-olds who have not really seen RSV before because we were all wearing masks and taking so many precautions. And so now we have, 3 or 4 years worth of children who are all vulnerable at the same time. So that's why there's much bigger numbers.
Okay. So someone asked, it seems that long COVID is also a bad outcome, and even a mild infection can lead to it. Why isn't there more public health focus on preventing infections?
Yeah, it's a very good question. I think long COVID is underappreciated, and partly it's because it's so nebulous. It's hard to define. It's hard to figure out exactly what the symptoms are. It's hard to figure out how long it's really lasting. Some people, it seems like, do recover, but it's very clear that some subset, at least so far, have not really fully recovered. So it is a huge deal. And there was a study recently in Nature Medicine that said it was a huge study out of the VA medical system. And it said for every infection, the risk of, organ damage and for long-term damage does go up. So every infection does matter, and it might be cumulative. It's one study, so, take that for what it's worth. But I think that the reason we're not taking preventing infections more seriously is because we don't have the tools. We don't have a vaccine that would prevent infections, and we aren't wearing masks. We don't want to wear masks. So it's not that we couldn't, it's just that I think people are choosing not to. I interviewed Peter Marks once a couple months ago for a story about these vaccines. And I remember I asked him why we haven't invested more in some of these other kinds of vaccines. And he said, now, looking back, it did seem like maybe they should have spent more time thinking about some of those things. He said they were blinded by the light of the mRNA vaccines and just didn't really see other alternatives. But now it's clear we need them. We cannot just put all of our eggs into the mRNA basket and hope that that'll be good enough.
But what other vaccines are out there? Johnson & Johnson, they're not giving anymore.
Johnson & Johnson, they are giving if you cannot or will not take the mRNA vaccines, and the same is true for Novavax, and which are both more traditional kinds of vaccines. I think J&J gets a bit of a bad rap. I know there's the risk of blood clots for young women, but I don't think it's significantly higher than the risk of sort of some of the side effects reported with the COVID vaccines. But because it is also specific to young women, there could have been a situation, for example, where you recommend that young men who are at risk of myocarditis from the mRNA vaccines take the J&J, and young women who are at risk from J&J for blood clots take the mRNA vaccines. There could have been more creative sort of recommendations than just, we're going to make J&J really unavailable, we're going to make Novavax really unavailable, and everyone's going to take mRNA. Novavax is around, it's available not just as primary, but even as a first booster. But you have to, again, be unwilling to get an mRNA booster or just unable to get one in order to get the Novavax booster. So, you have to essentially go with the same immune response you've had, whereas in theory, at least, if you were to take some of these other vaccines, you might get a better sort of mix and match repertoire of antibodies. You might diversify your antibodies, but we don't even fully know all of that yet. And I'll just say one more thing, which is mRNA vaccines are fantastic, but we do know that the immunity wanes, and they're fantastic for severe disease and death, but for infection, for example, the antibodies really wane. J&J has a slower start. It takes a while to pick up, but it seems like the antibodies last longer. And so in some ways, if you look at the CDC data, for example, and see, who was getting infected last year, all of last year, at some point until Delta in 2021, Pfizer and Moderna had the lead, and then they sort of crisscrossed. And at some point, J&J actually pulled ahead of both the mRNA vaccines in terms of preventing infection. So, it's more nuanced than just J&J is bad, mRNA is good.
Okay. Who is the farthest along in understanding the coronavirus and vaccines, i.e., which country or countries?
There's some development going on in Brazil, and India has approved one, Bharat Biotech, which also made the Covaxin. That's approved as a booster there. I think there's one that China just approved as sort of oral COVID vaccine. So there are a few candidates floating around. None of them are the US.
Yeah. And Russia had a vaccine, right?
Russia had a vaccine. I don't know if they have a nasal vaccine, but yeah, they had vaccines, but their vaccine did not prove to be that great.
Yeah.
The injected one.
I know. So someone said, I had COVID despite being vaxxed to the max. I took Paxlovid and felt cured. A week later, I got COVID again, which is the Paxlovid rebound. How common is this?
So when people started getting Paxlovid rebound, some high profile people like Dr. Fauci and President Biden started getting Paxlovid rebound. We were hearing that it's really rare, but I think the more we've learned about the cases, the more it seems clear that actually it's not that rare. We don't have exact numbers because it wasn't really studied. In the Paxlovid trials, they weren't really collecting viral load information and checking to see if people were getting sick again. So we don't have a good sense, but it looks like actually this might happen even with natural infection. That the virus comes in, your immune system kicks in, it gets rid of the bunch of the virus, and then the virus sort of has like a second wind. And if you remember, at the very early days of COVID, they used to say like, oh, your first week is actually not that bad. It's the second week that's really terrible. So there's more things that happen in your body beyond just the initial infection. Some of that had to do with, the sort of response, the immune response to the virus. But there's some ideas now that actually maybe this is happening all the time for people, even who are just naturally infected. Because you also hear about that, people who feel like they're fine, they seem totally recovered, and then they hit a wall again.
So despite all the numbers going up and the cases going up and people being hospitalized, people being sick, I mean, urgent care centers are packed, Broadway shows are packed, subways are packed, people aren't wearing masks. People are going to the gym, breathing heavily and working out. I don't think that's gonna, that also is going to lead to more infections, I think.
I mean, yeah, absolutely. That's how you get infected. Go into a crowded indoor space and huff and puff around other people without wearing masks. It's like pretty much a recipe for getting infected. I think a lot of people just don't care. They think of it now like it is like the flu because of all the doses they've had. And that's probably true for some number of, young and relatively healthy people. But people who have underlying conditions and older adults and immunocompromised people, they should really continue to be super careful. I mean, I would say, if I were immunocompromised, I'd be wearing a mask everywhere. And I think a lot of immunocompromised people still are.
Yeah. Are countries collaborating, I guess, on vaccines, or is it all through the World Health Organization?
So it's companies, right, that develop the vaccines. It's not so much governments. And so there are these companies in different parts of the world that are working on them. But the US researchers who are working on some of these are also collaborating with the companies in other countries. So Florian Kramer, who's at Mount Sinai, I think his vaccine is being tested in Mexico or someplace. So it's not so much that the governments are involved. The WHO gets involved after the vaccines are made. It'll sort of review the vaccine and offer a certification which allows health ministries all over the world to use aid money, for example, to buy the vaccine. So the WHO thing is sort of a separate, it's like a regulatory thing. And that happens after the vaccines are developed.
So whenever John Moore has been a frequent guest on the show, and he says, I don't have a crystal ball. And I know you don't either. But I was just curious. So let's say there's going to be a very bad winter surge. What do you predict is going to happen over the next year?
I'm reluctant to even predict the next few weeks, let alone the next year.
Okay, yeah.
I mean, exactly at this time last year, we were all feeling pretty optimistic. We all felt like we got the vaccines, we're all vaccinated. Some people also got, infected with Delta. Everyone was feeling pretty good. And it was like, we're going to have another variant come through maybe, but it's not going to be as bad. And then Thanksgiving Day, we heard about Omicron and everything changed. So I think we've all learned over and over now that trying to predict is a bit foolhardy. But I can say that if all of the viruses sort of go in turns. Like if RSV peaks and then flu peaks and then COVID peaks, and then maybe they're peaking in different parts of the country at different times, we're still going to have a rough winter because it's still a lot of numbers, but we may do okay. But if all three hit in certain places at the same time, the medical system is completely going to buckle under, because we already were stretched for hospital capacity with just flu some winters. So now if you add on RSV and COVID, we're asking a lot of a medical system that's pretty overstretched. So, and they don't have staff either. There are a lot of nurses who've left their jobs. There are a lot of doctors who've left their jobs. So we're talking about fewer staff, more patients, fewer hospitals. So it's not a great recipe.
And people are traveling, and there's fewer flights. Flights are packed. I went to London. The flight was packed.
I mean, flights are probably relatively safe. I now that we have more contagious variants, I don't know if their sort of ventilation systems are still good enough, but certainly before they were pretty good, and we did not get a lot of infections from flights. And Lydia Moraska, who's a sort of ventilation guru, she's an air quality expert in Australia. She actually took a carbon dioxide monitor with her on an Emirates flight. And I think Emirates made an announcement, said like, we change our air every 3 minutes or something like that. And so she tested it with her carbon dioxide monitor, and she said, it actually is really good. They're speaking the truth. So I mean, Emirates is one of the best airlines, so we're probably shouldn't expect the same thing from another airline, especially some of the American airlines that really are trying to cut costs. But in general, I think airplanes are safer. It's the airport that you have to worry about, all of the waiting time at the gates and standing in line, and buses to or from the gate. Those are the places. The airports themselves too, it depends how big they are. If they have really high ceilings, like the beautiful new LaGuardia airport, if you haven't been, it's so ridiculously nice for LaGuardia. It's kind of incongruous. But if really high ceilings like that, great. But if you're in a tiny little airport with a tiny little waiting area, then yeah, you're looking at that being your biggest risk.
I still wish planes had more ways to let people on, instead of everyone going, everyone lines up one by one, and then different groups and stuff. So
you don't have to, I never do. I wait until the very, very end, and then I go.
Yeah, but there's still only one entrance that everyone goes through, that corridor. So, I think that no matter how bad the virus is going to be, I don't think mask mandates are going to come back.
Never. No, I think mask mandates are a thing of the past. I think, well, I shouldn't say never, because prediction is not great, but it's going to be very, very, very hard for mask mandates to come back, because I think people have really decided that is a symbol of their freedom. And unless the political climate and the general sort of divisiveness in this country really changes, I don't see mask mandates coming back. Maybe in patches, like some cities, New York City, Boston, California, but not nationwide.
And what about schools? Do you think are they going to be affected? Are they going to go back to hybrid learning, or probably not?
I think that we've learned through the pandemic to keep schools open and keep them relatively safe. Do all the testing and have kids wear masks, in schools. At least some of the kids who need it, could wear masks. And now we do have, unlike early in the pandemic, we have masks that will at least protect you. You don't have to depend on the person who's infected to wear a mask. You can protect yourself regardless with these, N95s or KN95s. So that makes a big difference. And I think, a lot of schools during the pandemic learned to open windows and do as many things outdoors as they could. And there was a CDC study, I want to say last year, that looked at, or maybe earlier this year, that looked at what % of schools made changes after the pandemic. And they found that like half had done something like open windows and had stuff outside. And there's a lot of money for schools. There's just huge amounts of money. It's about $300 billion available to schools through various acts. And a lot of that can be used for ventilation. A lot of that is meant to be used for ventilation. But some schools are having a hard time figuring out how to use the money. They don't have like somebody telling them, an air quality expert saying, this is what you need. And this is what, this is how to retrofit your entire system. The school buildings in the US are really old. The average school building is 40, 50 years old, and a lot of schools don't have windows that are actually open. They're painted shut, or they're in places where there are wildfires and really, bad air pollution. Maybe they're next to highways. There's a lot of reasons that just opening windows isn't going to work. So those schools will have some trouble, but hopefully this infusion of money, even if it takes the schools a little while to spend it, will make some changes. They have until 2025 to spend the money. So they have a little bit more time to figure out what they can do. But once they use the money to make some changes, it doesn't have to be overhauling your HVAC systems, right? And I think that's one of the things that the White House and the Office of Science and Technology Policy are trying to educate schools on, is that it doesn't have to be a complete overhaul. If your school system is so old that you can't actually replace the HVAC system, then you can at least have air filters. You can at least do this other thing. You can have UV light. There are lots of things that you can do that don't involve getting a completely new HVAC system. But it's complicated now because of climate change. Some schools get super hot, and a lot of schools have had to close in the summer. Even in the spring when days got really hot, they had to send students home. So there's a lot more sort of interest in ventilation systems, HVAC, heating and ventilation systems, not because of infectious diseases, but because of climate change and heat and things like that. But hopefully because of those things, we'll also end up with better ventilation in terms of infectious diseases.
So another question. Have you been following the anti-vaccine rhetoric out there? Is anyone monitoring it? And the example she gave was that just yesterday, Died Suddenly was trending. Apparently, this is the name of an anti-vax film that just released. What can be done about that?
There is a lot of attention being paid to that. There are, at all different levels, there are scientists who are studying it. There are nonprofits that are paying attention to it. There are government organizations that are paying attention to it. I think most of those people got onto it a little late, which is why the vaccine misinformation really took hold. We didn't really start talking about how great the vaccines are until December 2020. And the anti-vax movement had its sort of act together and was getting out there, spreading messages and sowing confusion really early, like by April, May 2020. So once the misinformation is out there, it's really hard to contain. But there's no easy answers there. You have to flood this with as much information as there is misinformation. You have to just keep correcting it. The messages have to be simple, because misinformation really takes hold when it's simple. It's like, vaccines are going to kill you, or they're trying to track your movements. It sort of plays on fear, and it offers you this like single thought. Whereas if you start talking about the vaccines being good, it's like, well, the vaccines are, older people need it, and you need a booster for this, and it starts to get complicated super fast. So, if you are somebody who is confused, it might be easier to believe the misinformation than to try and wade your way through all of the scientific nuance. So I think that's one of the reasons it took hold. We have reporters at the Times who monitor some of this misinformation. They look at what kind of myths are taking hold, and they write articles to counter them. And during the pandemic, they wrote these articles that had like really beautifully crisp headlines, really to the point. Speaking of making things simple, the headline would be like, no, the Pfizer vaccine does not cause infertility. It's like, get right to the point. No clever title, just get the information out there. And there are, things you can do. Like if you see something on social media, this is all stuff I learned from my colleagues who write about misinformation. If you see a post, don't retweet it or spread it with a comment to say that you don't like it, because you're still giving it a lot of air.
Yeah.
And if you do have to do it, if you do want to retweet a picture, they recommend that you put a red line across the photo so that it's clear that you're saying this is not good and you're not just endorsing it, because people may not actually read your words. So it has to be more sort of visual. And there's a fine line to draw between intervening misinformation too early and actually giving it oxygen, or intervening too late after it's already been everywhere. And that's, I think, a fine dance that people are learning to do. And I think one thing they really learned during this pandemic, and I saw it play out during monkeypox, is that they learned that you can't just roll out the vaccine and say, here's the vaccine, come get it. You have to make it easy for people. You have to go where the people are. You have to have mobile clinics. You have to have pop-up clinics. You have to have, clinics set up in remote rural areas, or, poor neighborhoods, or neighborhoods where people can't afford to take the day off to go get vaccinated. So the reason I say I think that they've learned some of those lessons is because with monkeypox, it was older, it was Black and Latin men who were really at risk, at high risk, really disproportionately at risk. And they didn't do a great job of vaccinating them early on. Some of the clinics were in, sort of wealthier neighborhoods, or, around where white men lived. So, for example, the Chelsea Health Clinic had some of the first vaccines in New York City. And it's like, that's probably one of the most well-informed and well-healed populations you're going to get. So that didn't do a lot of great benefit for people who really needed it. And so what they did towards the end, they started to learn, and they started to go to Black Pride events. They started talking to community leaders. They basically started going very targeted events. And some of that thinking came from Dimitri Daskalakis, who's an HIV person, wasn't at New York City Department of Health, and then went to the CDC. But I think that all of that has sort of helped change the thinking to, it can't be that top down. You have to sort of reach out to community leaders, religious leaders, politicians, whoever is willing to put that message out there that people trust, because people do not make the decision based on the science, the MMWR. They make the decision based on whether their imam recommends it or has taken it, and whether the head of their family is going to take it, and whether their friends have it. And so you kind of have to get at it like that, rather than just push out messages from the White House all the time saying vaccines are great.
The other thing is, I know that when I was in the American Cancer Society, we would get barbershops involved, high school and college coaches involved.
Yep.
And they were more effective than some scientists getting up there and saying, I think you need a vaccine, or you need a prostate exam, or that kind of stuff. It was very, very, They once asked me when I worked at the Lung Association, how do we get people to get vaccinated? Because the vaccination rates have been very, very low. Just as hand washing rates are very, very low. And I said, well, announced there's a severe shortage. At the height, when the vaccines first came out, people were getting up at 3 a.m, going on 3 different browsers, trying to get an appointment. Their websites were crashing, desperate to get an appointment, willing to go. I know someone who drove from Arizona to Texas to get the vaccine. And now you can get a vaccine very easily. It's not a challenge.
On the other hand, though, when that's the approach, and when that's the sort of rollout you have, the people who get the vaccine for the first several months are people who can afford to drive from one state to another.
I know, yeah.
And there were people driving from their neighborhoods to some of the minority neighborhoods and getting the vaccines that were meant for that population. And, there was a lot of sneakiness and selfishness around, and a lot of that benefited white people. And so there was a, I think you do have to be very creative in the way that you get
there are a lot of private planes flying into Florida, and there are vaccines for sale by making a campaign donation. So look, the rich are always going to figure out a way to take care of it. Just as when Tamiflu first came out, they were getting prescribed. They didn't even have the flu. So people are that community does take care of itself. So I just want to talk. You're reporting. You went to India for a while and did some reporting, and you took a little break from the COVID reporting.
Well, in theory.
In theory.
Well, I went to India last December, and I left on December 6th. And I had made the plans, I think in September or October, but then Omicron broke right before I left. And my editor was like, "Where are you? Why aren't you here covering this?" I mean, he knew, of course, we had agreed on it. So, it was complicated, and I tried to do some stuff from there. But mostly I was reporting on other things. But, there are a bunch of other people at the paper who also write about COVID: Emily Anthes, Ben Muller, Carl Zimmer, and they all sort of carried the weight. And I was in India reporting on a bunch of different stories. I will say with great embarrassment that I haven't actually written any of them. I've reported all of them, but it's been a year and I've not had time to write them because I have just been on this hamster wheel of COVID, monkeypox, polio, nonstop infectious disease onslaught. But they are reported, and I really look forward to writing them. I think they're good stories.
When you mean reported but not writing them, what does that mean?
Which means I went to all the clinics that I needed to. I talked to the patients, I talked to the experts, I got the numbers, I got all the material, but I need a chunk of time to actually sit and wade through all of it and write it.
No, that's tough. So I think sometimes when someone tells me you can write about whatever you want, it's like, just be a little more specific. That would be helpful to me.
Yeah, every time I thought I would get a sort of break and get some time to write other things, something else would happen. There would be another wave, or there was monkeypox or whatever.
So we live in a time when people actually know who the journalists are. I mean, when I first wrote an article for the Times, it was just published and no one knew me, and and there weren't comments on a website, there weren't tweets about me or anything like that. So do you get a lot of personal comments towards you?
Oh yeah. Good and bad. Yeah. I think the pandemic, because it was so life and death, really did make people pay a bit more attention, because they were all trying to figure out whom to trust. There were so many different messages coming through. They needed sort of people to latch on to say, I trust the information from this paper or from this reporter or from this public health expert. So there was a lot of that, and it's obviously slowed down quite a bit now, but in the height of the pandemic, I was getting tons of emails from readers with questions because they could not get answers from the CDC or from somebody else, things like, I need to go to this wedding, do you know what I should do? That kind of thing. And I've also received death threats and horrifying emails and tweets and real ugliness. I think, we are in that era of where everybody is sort of a bit more visible, mostly because of social media. But the Times also is proud of its reporters. So, I'm sure you've noticed now the bylines at the Times all have pictures. Maybe not all, but a lot of the bylines now have pictures associated with them so that the readers can see who the person is. So that, that comes with good and bad territory. I think a lot of the bad came because it was COVID specific. I'm sure I'm going to get it even at other times, but it was particularly bad because of COVID and because I was writing about things that people didn't want to hear about. I was saying things like, the pandemic has not ended. in early 2021, and I was writing articles about vaccines and masks and schools and basically everything that people have been fighting about. So it put me in the crossfire sometimes, and it was really unpleasant at times to be on social media. I really slowed way down on social media, backed way off.
Well, that's good. That's slowing down. So I guess, with COVID, with ever-changing story, you don't always know what you're going to be doing each day. Is that hard for, is that hard for you?
These days I do kind of know what I'm doing every day because
Okay.
we don't have quite as much breaking news. But yes, for about a year and a half to 2 years, I really, every day was a scramble, preprints coming at us, news coming at us, CDC decisions coming at us. It was pretty crazy. I was writing, I would say 15 articles, maybe even a little bit more, few months per month, which is a lot for, sort of in-depth science reporting, as you can imagine. But, it was a period of time. I tried to think of it like women think of labor. I tried to think about it as like, okay, it's really painful, but it's not going to last forever. It's going to be some very intense period. And then at the end of it, it'll be done. So that's kind of what I tried to focus on and think. And so I just sort of kept going for the 1.5 to 2 years. And then I really did slow down this summer. And now I've been doing more enterprise stories. I got a whole bunch of enterprise stories off my desk, which feels great. And these days, so I do have a little bit more time. So I'm still writing news. I still write dailies, which are the news items. I still write those, but not nearly as often. And I have a lot more time to think about stories and to sort of connect the dots. There were times during the pandemic when my calendar was fully booked all day, every day with either phone calls or, this kind of stuff, webinars, whatever, radio stuff, things like that. And now, or I was on deadline. It was basically, I had no time to just not do something. And now I have entire days when I may have one radio interview. It's lovely. It's really very nice.
It is nice, yeah. Paul Offit told me that at the height of the pandemic and for a very long time, he would just sit in his chair and do interviews all day long. And
yeah, that's kind of how it was for me too. This office basically became my home, and my husband was home because he was laid off because he teaches squash, and nobody was playing squash at the time. So he would come up here with meals at regular times. So he really saved me. Now he's working again. So we're kind of back to normal now. But, at the time it was that's what allowed me, because he took on all the parenting and the cooking and stuff.
That's good. Yeah. So we're coming through the end. I want to thank you so much for being on the show. Before I go, I just want to talk about our next show. So Wednesday, November 30th, I'm going to interview Ryan Pryor, who was a reporter at CNN. He's author of the book, The Long Haul, Solving the Puzzle of the Pandemic's Long Haulers and How They Are Changing Healthcare Forever. And on Tuesday, December 6th, I'm interviewing a New York City psychiatrist, Sudhir God, who uses low-dose lithium to treat depression. And he claims he gets better outcomes than other doctors do with SSRI, such as Prozac and Zoloft. And it's also being used as a treatment for COVID. And so that's Wednesday, November 30th, and Tuesday, December 6th. And probably after that, we'll probably stop unless there's some really, great, exciting thing, and let everyone go shopping and take their breaks. So Apoorva is a great reporter. I'm thrilled that she came back to do an interview with us. I remember she was saying, I like this. I don't have to do any research. I just have to sit and answer questions. It's great. So I try and tell that to other people. It's not, it's not so hard. So anyway, thank you so much. Everyone have a very, very happy Thanksgiving.
Thank you very much. Happy Thanksgiving to you too.
Yeah, stay safe. And if you go to family gatherings, you don't feel well, don't go. I think that's the message. I'm not going. So anyways, everyone take care and have a good night. And thank you again. Okay. And Joe, thank you for taping this, and we'll be putting it on YouTube.